Hey, can you see me?
Yeah, can you see me? Someone walked right through me back there.
We might be dead. Are we ghosts?
How could I have done something like this to myself? What was I thinking?
I know, I was thinking I could have done something different too.
I wish I could have talked to somebody.
I think there are places that we could have went.
Can you show me?
Sure.
The ghosts travel further. Will we see more of the ghosts?
Yeah, we were able to use the concept of the ghost to do a bit of a walkabout to key services. And so they've gone on this journey and they actually become the eyes of the viewer.
Welcome to Where We All Belong. Our guest today on this series, in this episode, is Dr. Charuka Maaheswaran-Moeller. And she's going to be giving us a talk on the opioid prescribing algorithm. So don't get scared. It's a math term, but it's real practical application, and you won't want to miss this. So, Charuka, is it okay if I call you by your first name?
That's fine.
Okay. So you've already given us a wonderful talk on opioid addiction, and in there for our series earlier, and you mentioned that several local doctors and a pharmacist got together and to develop this algorithm around a safe way to prescribe opioids. Could you tell us a little bit more about that, please,
Sure.
if you would?
So the Comox Valley Safe Opioid Prescribing Algorithm package consists of the algorithm itself, which is a simplified one-page user-friendly flowchart of guidelines for the assessment, treatment and supervision of patients with chronic pain. And the package also contains patient handouts detailing the goals and hazards of opioid therapy, assessment and risk tools for opioid use, a standardized treatment agreement, which is a sort of contract between the care provider and the recipient, outlining the safe utilization of opioid therapy, and tips for supporting patients for withdrawal and wean down management. We've also liaised with the RCMP to develop a misuse letter, which can help keep agencies connected when opioids prescribed by physicians are found to be used illegally. We've also compiled a catalogue of local, regional and online resources for use by physicians and patients to help deal with chronic pain.
Mm-hmm. So this is a really interesting process. Why was this process developed in the community?
So, yeah, I'm glad you asked that. The algorithm was developed to enable a consistent approach to prescribing opioids across our community here in the Valley. And the purpose was threefold. One, we wanted to develop a local approach to increase the comfort and confidence of family physicians in safely prescribing opioids for chronic non-cancer pain. Secondly, we wanted to support physicians with their most challenging patients. It can sometimes be very difficult in that room to have that conversation, not only for the patient but for the physician also. And lastly, thirdly, we wanted to increase awareness of alternative treatments to opioids for chronic pain, including our wonderful local resources, which I believe is in your series too.
Mm-hmm. So who was this process targeted to?
Few people, although the algorithm was targeted specifically at family physicians and pharmacists, we envisaged and hoped for a knock-on effect in the community, which we've seen. Physiotherapists, the nursing centre and RCMP were positively affected, and even a local acupuncturist has reported increased usage of his services for chronic pain.
Can I just ask, what do you mean by a knock-on effect, for those of us who might not know that term?
Knock-on effect, I suppose, is a layman's term. Yeah. I would say that it's a benefit that wasn't the intended target, but
okay.
it's a ripple effect. Okay. Maybe that's my British English. And unfortunately, we're not able in the current system to track opioid usage, but anecdotally, the overall effect has been a decrease in the usage of opioids for chronic pain, which is a wonderful outcome for our project.
So how did the need for such a process get discovered?
Well, locally, the Comox Valley Division of Family Practice identified prescription opioids as a big concern in our physician community and in our community. And from that, a workshop for physicians and pharmacists was organised to raise awareness of the issue and provide education on safer and more effective treatments for chronic pain available locally and detailed online resources. This helped to improve coordinated treatment of chronic pain with allied health professionals. A working group was established to develop a safe opioid prescribing algorithm, which included a standardised treatment agreement and information resources to enable a consistent approach to prescribing opioids in our community.
When did local physicians come to the conclusion that there was a problem with prescription opioids in our community?
So in September 2013, which is a few years ago now, at our local AGM, so our annual general meeting of the Comox Valley Division of Family Practice, we agreed that opioid prescriptions were a big concern in our community, and as physicians we are often the canaries in the coal mine. I was selected as physician lead to spearhead the initiative, and I asked a more senior colleague who had been in the area for over 20 years to work with me. We organised a community liaison event in November 2013 that we attended to talk to our community representatives to see if our bellwether was ringing correctly, and it was. From there we surveyed our physician colleagues to see if they supported the development of a standardised opioid prescribing protocol, and they did at an overwhelming 92%.
Wow.
And then in June 2014, we organised a workshop including physicians, pharmacists, nurse practitioners, RCMP and Island Health to increase awareness and collaboration. A working group then stemmed from that, which developed the algorithm and package, which was launched in March 2015. And we evaluated our work recently in December 2015 and found that the initiative has resulted in increased comfort of physicians in prescribing opioids appropriately, with 73% of physicians using a treatment agreement, which is wonderful, and of which 38% are using our developed treatment agreement.
So this has been very much a local project, a local initiative, but has this information been used anywhere else?
Yes, well, here, for example. And even though these resources were developed specifically for local use, they've been integrated into the local module resources used for education by the Practice Support Programme, which is a provincial physician education programme. And our work has been selected to be presented at the upcoming Provincial Quality Improvement Forum in end of this month, where I'm presenting at a conference.
Oh, that's impressive. So for the viewers, what are the key points that they might want to know about the prescription of opioids or the prescribing of opioids?
So prescribing opioids for chronic pain is still a controversial practice supported by little evidence. There are significant risks associated with long-term opioid use, whilst benefits are typically modest. There are many treatment options for chronic pain which have better efficacy and evidence behind them than opioids. Prescriptions written largely in good faith and mostly by family physicians are by far the biggest source of opioids in Canada, and some people are actually medicating their depression with opioids. There is no such thing as a painkiller where chronic pain is concerned. Only a minority, 1/3, derive some pain relief. Even fewer will see functional improvement with opioids. And working closely with your family doctor and pharmacist while taking opioids is crucial to ensure that you are using them safely and that they are meeting the goals of treatment.
Thank you so much for all this fantastic information. I'm sure that it's going to help many of our viewers when they go and have conversations with their family physicians, and also help the physicians to know that more of the public understand the recent changes in the protocols for prescribing opiates. So thank you so much for your time.
Thank you for inviting me.
Well, it's one that doesn't hate people that have problems with drug abuse, I would say, for sure. Has facilities and programs that can help people.
To me, a compassionate community is one that the residents are engaged, so that they're aware of what's happening in their own backyard, and that they are willing to give up or provide their time and or resources to help each other.
compassionate community for me is a community that makes sure that no one is left behind, that everybody has an equal opportunity to succeed and to have a healthy lifestyle.
Today we have a very special guest, Dr. Charuka Maaheswaran-Moeller, and she will be giving us a talk about opioid prescribing.
You may think opioids has nothing to do with you, but you might just be surprised, so stay tuned for a very interesting talk.
So, opioids are a vast subject, but here I wish to give you an overview of the current situation, how we got here, and what we hope for the future. Data collected in 2012 indicated that 410,000 Canadians had reported abusing medications such as opioids in the past year, more than double the number the previous year. Health Canada reports over 80,000 Canadian kids used prescription drugs to get high in 2013. Canada is the second highest per capita consumer of opioids after the US. In the past 10 years, our per capita use has doubled. Related deaths have also doubled and are now twice that of HIV. According to US Centre for Disease Control, in 2008, prescription drugs were involved in more overdose deaths than cocaine and heroin combined. In British Columbia, 80 to 90 people die from opioid overdose each year. Each month, 7 or 8 people in BC under the age of 60 die from overdose. Just one extra pill is enough to tip the balance for a person's breathing centre and they overdose. This is especially a danger if opioids are used with alcohol or benzodiazepines, which in themselves depress breathing. In Ontario, twice as many grade 7 to 12 students abuse painkillers as smoke. 1/5 of students indicated easy access to prescription painkillers without visiting a doctor. School children use prescriptions to get high. 55% of them were given opioids by friends and relatives. Unused opioids are sometimes brought to parties called pill, farm or Skittles parties, where tablets are selected from a pool of medications. With opioids in particular, some products contain enough active ingredient in a single tablet to cause death in a naive user, especially if mixed with other sedatives or alcohol. The face of addiction is also changing. Americans aged 50 to 69 years represent the fastest growing population of opioid addicts, and the number of people over 65 who have at some point abused opioids increased by 34% from 2011 to 2012. This increase in prescribing of opioids has disproportionately affected certain groups of people, especially First Nations and those with low income. One major reason is the paucity of access to affordable alternatives to deal with chronic physical and psychological pain. The new evidence also seems to confirm that marijuana truly is a gateway drug for heroin users. The route to drug abuse for the susceptible typically starts with marijuana and progresses to prescription painkillers before ending with heroin. Additionally, opioids are being cut with other drugs and even purified to increase potency. It appears that some think, why not get pharmaceutical grade instead of street grade drugs? The price is the same and there are the obvious risks of going to a dealer. BC has a database that lists all prescriptions called PharmaNet, but there is no current information on just opioid prescription and there is no national database. There is some data from some of the provinces and territories, but it only captures prescriptions that are covered by drug plans. We need a standardized, coordinated system of monitoring and information gathering about opioid prescribing. How do we get here? Well, until the 1990s, because of concerns about the potential for addiction, physicians were generally reluctant to prescribe opioids for chronic non-cancer pain. This reticence stemmed in part from the widespread therapeutic use of opium in the late 1800s and early 1900s, which led to serious problems with addiction. The introduction of long-acting oxycodone and controversial aggressive marketing campaigns beginning in the late 1990s led to a change in attitude amongst physicians, particularly family physicians, especially when national organizations endorsed and promoted the use of opioids for chronic pain. There was also a general sense that because opioids received approval from regulatory agencies such as Health Canada and agencies such as the US FDA, that they are not as potentially addictive or harmful as illicit street drugs, such as cocaine and heroin. People are often inclined to treat pain as soon as it arises, and opioids can be overprescribed, even for short-term pain. In one study of skin surgery patients, 1/3 were prescribed opioids, and half of these patients planned to keep their remaining tablets for future use. Almost all people who take opioids regularly for more than a few weeks will develop withdrawal symptoms when they stop them or miss a dose. Many mistake the pain of withdrawal as their chronic pain, and when they take their missed dose, assume their pain improved because the opioid was relieving their pain. It was more often just relieving the pain associated with the withdrawal. And symptoms of opioid withdrawal are similar to a severe flu and include chills, headaches, joint aches, abdominal cramps, nausea, vomiting, anxiety and fatigue. They usually begin within 12 to 36 hours of reducing the opioid, are most severe for the next 1 to 3 days, and then begin to fade over the week. Some people report feeling tired and mildly unwell for 2 weeks after completely stopping opioids. After this, there might be a temporary flare, but some actually report less pain when the flare subsides. You cannot die from opioid withdrawal. I encourage people not to go over 6 to 8 weeks if possible, especially post-operatively, as I want to check that there are no complications and that the operation worked. The body needs a chance to heal, and pain is a good signal of something awry. I find that after this chat, more often than not, patients don't fill their prescriptions for opioids at all, and therefore don't put themselves at risk of their many side effects. Prescribing opioids for chronic pain is still a controversial practice, supported by little evidence. In general, there are significant risks associated with long-term use, whilst benefits are typically modest. Long-term benefits of opioids for axial low back pain, headache and fibromyalgia are unproven, whilst risks include addiction, overdose, depression, cognitive impairment, chronic constipation, traffic accidents and fractures due to falls. The problem of abuse and overprescribing and diversion go hand in hand. Prescriptions written largely in good faith by family physicians are by far the biggest source of opioids in Canada. The challenge remains that there is no objective test for assessing pain, and therefore the prescription of opioids rests to a great extent on mutual trust between physicians and patients. Unfortunately, a national survey of physicians in April 2014 also showed that threats and violence against healthcare providers who prescribe opioids is a relatively common occurrence, leading some to be manipulated or bullied into prescribing. There are many treatment options for chronic pain which have better efficacy and evidence behind them than opioids. There are substantial resources one can find on the internet, for example, the Pain Toolkit and the Pain Toolbox, as well as local resources. According to recent research, people with depression have higher than normal levels of proteins called cytokines. Cytokines can trigger pain by promoting inflammation, and we have long known that depression and chronic pain are interlinked. One leads to the other, and often treatment of depression helps alleviate chronic pain symptoms and improve functionality. In fact, some antidepressants target chronic pain specifically, and their side effect is elevation of low mood. The body's natural painkillers, or endorphins, are weaker than manufactured opioids and do not produce euphoria and the general feeling of well-being that opioids do. Hence, some people are actually medicating their depression with opioids, which are not their intended purpose and is, of course, inherently dangerous. We also know that long-term use of opioids inhibits the production of both the body's own opioids and their receptors for action. So where to now? The federal government in its 2014 budget said it would spend $44.9 million over 5 years to address prescription drug abuse as part of the National Anti-Drug Strategy. The strategy, headed by the Department of Justice, had previously dealt only with illicit drugs. Discussions between the CMA, our professional union, and the Federal Health Minister outlined the need for a more robust pain management education strategy for medical students, residents and physicians, as well as the need for increased awareness of non-pharmaceutical options for pain management. Hopefully, all this will mean more funding for alternatives to opioids. updated guidelines for opioid prescription from our governing body, the College of Physicians and Surgeons of BC, from January 2014, detailed that there is no such thing as a painkiller where chronic non-cancer pain is concerned. Only a minority, 1/3, derive some pain relief. Even fewer will see functional improvement with opioids. Treating chronic pain is very different from management of palliative end-of-life pain. Applying palliative care principles does not work. Treatment decisions must be based on comprehensive, frequent reassessment, hence the importance of a comfortable therapeutic relationship with your family doctor, someone who knows about you and cares about you. Informed consent involves the use of written and signed treatment agreements. There should be access to PharmaNet with an updated profile every time prescriptions are renewed. Describe opioids prescribing as a trial. This is special prescribing that is inherently dangerous and subject to regulatory scrutiny, not medicine as usual. Make sure it is understood that opioids may be tapered and stopped if problems arise. If you don't see a compelling improvement in pain relief with functional benefit early, then it is reasonable to stop the trial. If prescribing, use a low dose. Higher doses cause opioid-induced hyperalgesia, which is increased pain, mood disruption, sleep disturbance, hormonal dysregulation and gut dysfunction, and are not scientifically validated. Most fatal opioid overdoses involve the concomitant use of sedatives, particularly benzodiazepines. Co-prescription of opioids and benzodiazepines should be avoided because of their harmful effects on breathing. If patients are already on this combination, make sure it is understood that one or the other will be stopped. Tolerance to benzodiazepines and other prescription sedatives develops quickly. They do not improve sleep architecture or sleep quality. Their use should be reserved for short-term use only. And avoid prescribing long-term opioid therapy to high-risk groups, for example, young people, those with major psychiatric illness or personality disorders, patients with a personal or family history of addiction, and those with functional somatic syndromes like fibromyalgia and IBS. Routine, occasional, supervised random urine drug screens should be performed. Where misuse is likely, these should be frequent. And frequent, modest dispenses, rather than hundreds of pills at a time, should be the rule. Locally, the Comox Valley Division of Family Practice identified prescription opioids as a big concern in our community. From that, a workshop for physicians and pharmacists was organised to raise awareness of the issue and of alternative treatments to opioids. Several local doctors and a pharmacist worked together to develop an algorithm, a safe and consistent way of prescribing opioids in our community, which included a treatment agreement and information resources for patients, physicians and pharmacists. In addition, closer ties have been forged with the RCMP and community pharmacists to tackle the problem of diversion. There's also been the recent establishment of a local chronic pain clinic which enables specialist supervision of patients suffering with chronic pain. A much welcome addition to our community, as in my opinion, treatment of chronic pain is a specialty in itself, like psychiatry or child health. There is still much to do, but we've made a start. Acknowledgement of the problem is the first step to change, and I, as a mother and physician, dream of a community where medications are used safely by the intended recipient for only the time necessary. Opioids will never disappear from our world, and nor should they, but they must be used appropriately. Not every ill needs a pill. We need to have faith in our bodies. They are wondrous things which have an amazing capacity to endure and to heal.
Tom, when you think of a compassionate community, what does that look like?
To me, it would be a community that cares for, values, and embraces all the members of the community, not despite their differences, but because of the value that the diversity they add.
Thank you. Cindy, when you imagine a compassionate community, what does that look like to you?
Well, I imagine a compassionate community that its members work collaboratively together to help and support and care for the members that are less fortunate than, say, myself. and really strive to help alleviate or lessen people's pain and suffering.